Hello, my friends. My name is Dr. Saif, and today we are going to discuss the ICU-acquired weakness, which is a common and severe complication of critical care, very commonly seen in critically ill patients. And it is troubling because uh, when you are expecting your patient to come out of ventilator after the indications for mechanical ventilations are recovered and improving, and the critical illness of the patient is also responding to the treatment. You want your patient to be, out of ventilator, but it doesn't happen because of this problem, the ICU acquired weakness. So this is where we need to know about it, and it is interesting to know about it in depth because it affects the quality of life of the patient by increasing the morbidity and the healthcare cost. So let's start with a case scenario as usual. This will definitely sensitize you to understand about this problem a bit better. A 65-year-old male with a past medical history of hypertension and type 2 diabetes mellitus admitted to ICU 10 days ago for septic shock secondary to pneumonia. He required mechanical ventilation for 7 days. He required norepinephrine for shock and also the steroid. Now he is recovered, he is awake, off sedation, but complains of generalized weakness. He says, I can't lift my arms and legs. On examination, there is a symmetrical bilateral flaccid weakness. The MRC score, that is the Medical Research Council score used for the assessment of motor power, is 3 by 5 in all limbs. And when you check the deep tendon reflexes, they are negative. However, there is no sensory deficit. When we tried the spontaneous breathing trial, he failed due to weak respiratory effort. On investigations, there is normal levels of electrolytes. However, there is mild elevation in creatine kinase, 300 units per liter. So with this, information, all inputs, all clinical inputs, investigation, etc., and physical findings, including what is your most likely diagnosis. So as we know, that this patient had critical illness, recovered, he's on ventilator, but he can't use his upper limb and lower limb. The power is less, 3 by 5 in all limbs, absent tendon reflexes. So he seems to have some kind of weakness. And because it developed after ICU admission, so we will call it as ICU acquired weakness. So we should know what are the differential diagnosis, how to detect ICU acquired weakness, what are the risk factors, pathophysiology. All these are going to be our learning objectives for this session today. So we need to define, we should know how to identify major risk factors and pathophysiology of ICU acquired weakness should be known. We need to know about its detection clinically and laboratory wise to rule out mimics. Mimics mean differential diagnosis, and apply all these information to prevent and to manage the ICU acquired weakness. So these are going to be our learning objectives today. Regarding the definition, it is straightforward. However, it is usually the diagnosis of exclusion, excluding all other causes, all alternative possibilities which may be related to weakness in ICU patients. For example, we need to rule out the myasthenia gravis. We need to rule out the electrolyte deficiencies like hypokalemia, hypomagnesemia, hypophosphatemia. We need to rule out the nutritional deficiencies as well. Okay, and neurological abnormality. Patient should be alert, conscious, so there shouldn't be any neurological problem like a stroke. So if we rule out all other things, and CK should be normal, creatine kinase should be normal to rule out rhabdomyolysis. Okay, There shouldn't be any extra sedative or use of muscle relaxant. So all those things we should rule out. And then we come to the diagnosis of ICU-acquired weakness. So it is a symmetrical, generalized weakness involving all four limbs in critically ill patients with no alternative cause. Now, regarding the subtypes. So, ICU-acquired weakness has basically two subtypes, polyneuropathy and myopathy. Okay. And then we have third type, which is a combination of polymyopathy and neuropathy. So this type of polyneuropathy, which develops as a result of critical illness, you know, various types of sepsis, cause of sepsis can lead to this, and also the use of muscle relaxant, destroyed. So there are multiple factors which can cause critical illness, polyneuropathy and myopathies. So these are two subtypes, but commonly what we see is the combination of or overlap of CIP and CIM. Okay, so you should know the subtypes. So there are mainly two subtypes and one combination part. Now regarding the epidemiology, why epidemiology is important? So that we will expect it in our patient. Okay, suppose something is quite common, then we should be thinking of that entity or that diagnosis commonly. Okay, that should be in the first priority, or the first differential in our workup. So epidemiologically, up to 60%, uh, 50 to 60% of patients who are on mechanical ventilator can develop ICU acquired weakness, and this figure can go up to 80% if patient had sepsis or multiple organ dysfunction syndrome. So you can see here how common this is. More than half of the patient, up to three-fourths of the ICU patients may have this kind of problem, ICU acquired weakness of mild to moderate to severe, category. So we can categorize the weakness depending upon the MRC score. All right. Now regarding the pathophysiology, this is also important. What are the key pathways which can uh, which can be implicated in the development of ICU-acquired weakness? So, as we know, sepsis is the first and foremost reason. So, in sepsis, what happens? As you know, this is the this is an abnormal hyperinflammatory host response to infection associated with organ dysfunction. This is the definition of sepsis. And markers wise, we have elevated level of tumor necrosis factor alpha and interleukin 6. So these are pro-inflammatory cytokines which are highly elevated in case of sepsis. These cytokines are generalized. They are widespread in the body, and they don't leave muscles and neurons. So what happens? These inflammatory mediators can paralyze the mitochondria. And the mitochondria are the seats of ATP production, the energy production. They are powerhouses of energy. So muscles and neurons for their functionally, they require lot of energy, and in turn, they require lot of mitochondrial activity for ATP turnover. So whenever there is a mitochondrial dysfunction, there will be impact, the great impact on the nerve conduction and the muscular transmission, neuromuscular transmission. And later, these patients will develop some kind of weakness, flaccid weakness also. So this is one important pathophysiological pathway. There is another pathway which says that there is a microvascular ischemia. So we know there is a microcirculation in the body which supplies glucose to all the tissues, nerves, muscles, including. So what happens in case of endothelial dysfunction, in case of especially sepsis, these microvasculature get blocked because of microthrombosis. And due to block, there is a decreased blood flow to the tissues,